they would have an abrupt feeling of pain. And that abrupt feeling of pain comes although they are taking stable medication, and although they are basically trying to keep up with their life for a quality of life sometime rather than treatment. However, this breakthrough pain comes out of nowhere, and you cannot predict that it's coming. You know, it just comes, and as that pain exerts, you have to have a medication that would do the job immediate and within that period of time. And usually the median time goes from 1 minute all the way to almost 2-3 hours, but with a median time almost like half an hour. We have to think of something that could be used in order to be able to get rid of that breakthrough pain. And if you want to understand it in a better way, this simple skit, I usually like to put it, we have somebody with persistent pain because of chronic type disease they have, mostly in oncology and in cancer therapy, or with multiple sclerosis. And as the time passes, although they have that control pain management, from time to time you're going to see the scales for their pain comes as the breakthrough pain explore. You have to make sure that you give them the medication at the right time, rather than giving them over medications of opioids that won't work when the time for the treatment is needed. So basically, when you think about that breakthrough pain, usually it affects the quality of life for those patients. They cannot go enjoy their life, they cannot work well, from time to time they would have issues. So basically it adds to their depression and to lower the quality of life they could have. So basically, when you think an ideal treatment for breakthrough pain, you want something that would work, be strong, can work in a fast onset of action, and within a sufficient duration of work. Also, you want to have the least side effects and something easy to administer. Those breakthrough pains come scattered, and most of those patients will be at work, will be at home. You want to have something easy for them to be able to administer. And when you look to the options for that breakthrough pain treatments, globally, the first option is injectables, because injectables basically will give you the onset of action immediate. The problem with the injectable that it's invasive, and you know, imagine somebody at work at the desk and they have breakthrough pain, or they have to go look for a place where they have sterile injections they need to give themselves. So, and it's really difficult, even as they grow with age, when you have a family member taking care of them, sometimes not all of them are, for them, easy to use those type of injectables. The other easy administration position to think of is to use the transmucosal drug delivery. And when we talk about transmucosal, we basically talk about administering through the mucosal membranes, which are all over our body. We have mucosal membranes inside the mouth, inside the nasal cavity. We do have it all over, you know, and you could use any of those as a route of administration. The good thing about the transmucosal drug delivery is non-invasive. You don't have to inject to be able to give the dose. They usually, so there is no risk for infection. Family members who are taking care of elderly people and they had a breakthrough pain, they can easily administer the drug. There's no needle stick, and there's no need to swallow, as some patients, they don't like to swallow medications at an elder age. So for the transmucosal routes, my research group basically focused on the nasal transmucosal as well as the oral, including the buccal and sublingual. So talking about the intranasal drug delivery, people will think the nose is a small organ, so basically we use it like for allergy, for like cold medication. Well, the nose can be used for systemic drug administration, and it's been found, and there's in fact a lot of medications on the market that would deal with systemic drug delivery based on nasal drug administration. Now, the nasal drug administration, there's a lot of advantages that you pass the hepatic path metabolism, you bypass this issue, it's easy to administer, and usually because of that nice vascular area, you would have a fast onset of action. And one more thing is that basically when you want to target the brain for drug medications, you have to pass the blood-brain barrier. While with the nasal and with the intranasal drug delivery, you don't have to worry about passing the blood-brain barrier, because there's the olfactory neurons that connect the nasal cavity all the way with the central nervous system. some criteria for medications. I could use them for intranasal drug delivery. It has to be a potent drug. Why potent? We talk about the nasal cavity. It's a small cavity. I cannot put 1 gram of medication there. I cannot put certain, it has to be potent, used in a small amount to be able to administer the drug in the nasal cavity. Solubility is a big issue. It has to be soluble in a way so it will be absorbed and it will not create irritation within the nasal cavity. And of course, the molecular size of the compounds. Mucociliary clearance is a very important thing. Don't forget, the nose is designed, subhanAllah, that it would reject anything foreign come to inside the nasal cavity. So basically, you have to make sure that whatever medications you're using, they do not trigger that nasal clearance process, and they do not do the irritation within the sensitive nasal mucosa. Starting with the tetrahydrocannabinol. Tetrahydrocannabinol, the well-known dosage form for it is the soft gel capsules called Marinol. And although it's absorbed very well from the GIT, people will think because it's lipophilic, maybe absorption is an issue. In fact, it's really more than 90% of the dose is absorbed, which is very good. However, what reaches the systemic circulation is only 10 to 20% of that dose because of the extensive first-pass metabolism. So it is really a good model to try to go for the intranasal delivery. So because of the easiness of administration and potentially it could be used for fast onset of action. However, looking to the structure of tetrahydrocannabinol, you would expect that it might have some mucociliary clearance, and of course, trying it in the lab, it proved that there is some issues with irritation with the tetrahydrocannabinol delivered through the nasal cavity. There was also a big challenge with the tetrahydrocannabinol in order to have a good dissolved form of it because of the lipophilicity of the compound. We've been able to work with it, make some sort of mucoadhesive gel, try to give the dose some time to be absorbed through the nasal cavity. And looking to that, in fact, we managed to do the studies and work it from the in vitro model to the in vivo model using an animal model, and usually we use our rabbits. And by the time we did this work, in fact, it was published, it was the first work published on conscious rabbits. We usually use conscious rabbits when we apply nasal medications, especially when it's in mucoadhesives, because we want to make sure that we are mimicking the clinical setup. Usually like using animals under anesthesia while they are totally relaxed and asleep will not give you the correct clinical setup where you have some movements, some activities within the nasal cavity. So that was the first work done with conscious rabbits using a lipophilic model with drugs such as tetrahydrocannabinol. And if you look at it, we tried to use intravenous, a gel formulation, as well as a solution of tetrahydrocannabinol. And as you can see, there was not that much change between the solution and the gel. And there was some irritation, in fact. However, something really interesting to look at was basically the shift in the Cmax as you move with the gel, which is the one with the navy blue color. And you can see that the gel, in fact, made that good contact with the mucosal membrane and kept the absorption even after the first 20 minutes, if you look to the scale here. And that's why you have that nice shift for the Cmax with the solution nasally administered versus the gel nasal administered. However, there was not that much changes in the area under the curve, which did not change a lot when you come to the bioavailability measurement. Now, those who would know me, they would know I would not give up on a drug because I know that tetrahydrocannabinol have a big potential to be used. And the irritation is an issue, and really we have to work on it. So I thought, well, it's good, let me move forward and try it for sublingual drug delivery. So I had a postdoc at that time. I said, well, let's go ahead and go sublingually. Nasally, it caused that irritation, and although the drug is absorbed well, but irritation will not make the drug go beyond to drug development. You want to do work, you want to publish work, but also you want to do collaborative work where you can see your molecules, your formulation, make it all the way to the market size, and you feel proud that you are benefiting humanity. So we worked on it, and unfortunately, sublingual absorption with tetrahydrocannabinol was very low. Although there is a company there, they thought even with 10%, they could survive and have it all the way, but I thought sublingual is not a good model for tetrahydrocannabinol. At that time, we had a project coming in for another compound, and that time they came to us and they said, we have issues with irritation and we want to deliver it nasally. You have to find a way. And that time we were working with nanotechnology, and I thought, well, let's try nanotechnology and see if we put the drug inside those nanoparticles. In theory, we are making some sort of isolation of the drug from the mucous membranes. So basically, maybe that irritation factor will not be triggered. So that time we used that mono drug, and we thought this could be a beneficial work. If that worked in this irritating the drug, we can apply it back to tetrahydrocannabinol, which we did not do yet. So if somebody want to do the work, it's available. So that time we did chitosan alginate nanoparticles for that X drug, and I'm sorry I could not put the name because this is an industrial project and they were so much big deal about the drug. However, honestly, when we did the nanoparticles and we did the animal work, we had tremendous outcome when we looked at the irritation process. And those who works with rabbits, you would feel like those rabbits are like your pets. You know them very well. You work with them, so you feel happy when you have a medication given intranasal and they don't have issues with their nasal mucosa. So we did the chitosan alginate, and we tried to go down to the level of not beyond 50 nanometer because we want to have a good absorption profile for the drug. And when we did the nasal irritation studies, the control had irritation process 2 out of 3, while the one with the nanoparticles did not show anything. Of course, this is really an ongoing work, and hopefully I will pursue it when we pursue the funding. But by using this model with the nanoparticles to decrease the levels of irritation nasally, this can be a nice technology to be used for multi-medications as a carrier to decrease the level of irritation for sensitive surfaces such as the nasal mucosa. So I like this sketch really because it shows the absorption of transmucosal from the mouth of those opioid medications. And if you look at them all the way to the right, there's the buprenorphine, the Stadol, which made it to the market. And by the way, this came from University of Kentucky. Dr. Anwar Hussain, who was my advisor, made that intranasal drug delivery model for buprenorphine and made it all the way to the market. And if you look also close to it, there's fentanyl, and believe it or not, well, that made it to the market, but it came from my lab, so here we go. But this is really some sort of medications that's been a study that's been done by Wimbrand Group, and Wimbrand Group, they show that those opioids, they are really well absorbed from the sublingual or from the mouth mucosa. So you just have to come up with the right dosage form to be able to deliver it to the patients. In between that work, we did some work with oxycodone and sublingual oxycodone. We were working on the pH, the formulations, trying to see how we can enhance the absorption. And of course, as you get away from the ionization of the molecule, you make it more neutral, although you may be decreasing solubility, but you are enhancing its absorption profile. So as we worked with that, we decided that time we had a good project from a company, and in fact that guy was a graduate of University of Kentucky, maybe 15 years back, but he has some industrial ideas. And he came and he said, there is fentanyl lollipop made it to the market. And those who knows fentanyl basically is really high, big market for breakthrough pain, for cancer management, especially with children and with elderly, where you can just give them a lollipop and tell them, put it in your pocket. Whenever you feel pain, just start sucking, and that's it. It works. So it's a huge market. So he came to my lab and he said, you do transmucosal drug delivery. They made a lollipop. I want something that would work. I said, well, let's try sprays, because if it goes through the transmucosal membranes, just change the dosage form. So that time we worked with their company, and we prepared for them and developed that sublingual spray, and it was a lot of formulations back and forth, trying to work it out. But that time we did some sort of work for them on the fentanyl, and we did work over 12 formulations, but the top 2 between those was a fentanyl base and a fentanyl salt with some ingredients And as you can see, there is really very nice area under the curve, which means we are attaining good bioavailability. And back to the breakthrough pain, when we talk about sublingual, or we talk about any mucosal membrane, we're talking about fast onset of action. So when you try it on animals, and it's really bioavailable, and there is no irritation, this means you can do the allometric scaling, go with animals, define the therapeutic dose, and then take it all the way to the clinic. And that was really a successful story, because when we did the pharmacokinetic work on animals, we found that we are enhancing the bioavailability of the drug. In fact, up to 82% bioavailable compared to the intravenous, just by using unique formulation in the base. Understanding the regulations of the FDA, at that time we were working with them, it came from my lab, but because of the potential abuse of fentanyl, we decided to go with a single dose. So basically it's a spray, used for one spray and then you throw it. So basically there is no addiction potential, something to let it go through the regulations of the FDA, and we worked so hard with the company, and believe it or not, Subsys made it to the market, but it's really started from a research at academic lab, and that's what I'm trying to pass to you guys here. It's not about Subsys or about Stadol or about, usually nobody can do it alone, and you have to do that collaboration. And collaboration, don't do it just at the level of funding and basic research. You need to think globally, beyond. I want to think of drug development. I want to understand how I can take something all the way from the bench to the market. And those faculty members, those researchers who understood that secret, they made it really well. I would say well financially, but this is not what you're looking for. You want to look for really satisfaction, where you work and you found your molecules, your formulations, make it, and it benefits people. So I wish you all luck with your research, with your work, wherever you are. I know pharmacists, they have science and research in their blood, and going to PharmD or staying in national pharmacy, it does not matter. Wherever you want to go, there will be something in those 5 years of studying or 6 years of studying will not go just by dispensing medications, and you would go beyond. And of course, if you have a chance to proceed, be a faculty, get your PhDs and do more research. وطبعا بالنسبة للأكنولجمنت, I will acknowledge I have a huge research group has been with me since the past 15, 20 years. I would encourage you to go to the publications, see those people who work with me. I would never be able to do it without them. And thank you for being here, and if you have any questions.
Thank you, Dr. Abir. I have time for one question. Please.
شكرا دكتور عبير. يعني الفنتانيل اوكي فيري نايس دروج وليد من الناس اللي عندهم سي اي، بس انا بيهمني يعني رايك بعد 5 سنين رح اشوف باراسيتامول او بنادول او كتافلام يوكوزا برتاح.
Why not? In fact, as we talk, I have people working on pediatric formulations for Advil, which is ibuprofen.
What about insulin?
Now, we have to be very careful when we talk about insulin, at least from my perspective, and I would just say it now. I would just say it now, but if you ask me outside the door, I would say no. Insulin nasal would never be a success. Those who do nasal drug delivery, they would understand the nose integrity is very important. And when you work with high molecular structures, high molecular weight, on chronic basis, now insulin is a chronic-based medication. If it's something for breakthrough pain, for migraine that you would use seldomly sometimes, that would be fine. But something that you want to take daily, impossible. With that molecular weight. So whenever I see companies pumping money and putting an insulin nasal, I say, what's down the drain? Honestly, that's my opinion. Behind you.
Of course, doctor, you know that the mucosa of the brain is very sensitive to this medication. So, how this mucus membrane terminates the drugs by this route? And what is the effect of repeated use of these medications, or the efficacy of the membrane to allows the drug to go and meet to the bioavailability or repeated dosing for the patient.
Yeah, of course, the integrity of the mucous membrane is very important. And part of just not doing research, just part of FDA regulations, whenever it comes to registration of medications, it depends on the use of the drug. And this is back to the point. If something you want to use in a frequent basis and a chronic basis on the nasal cavity, I can tell you from now it would never pass the FDA. Because of the integrity of the nasal cavity and because it's there for a job. It's a smell and it's protecting to the respiratory system. So if you want to use it, it has to be something that used seldomly, abrupt, like somebody had a cold, somebody had a migraine, that's not coming every day or every week, you know, so you would be able to use. But on a frequent base uses, the nasal cavity would not tolerate such treatment.
Apart from the issue, smoking can always, I think,
Sorry, I cannot hear you. I'm sorry. I cannot hear you.
I mean, for example, for the cancer patient, if we allow him to smoke cannabinol, like cigarettes, is it, it's okay, I think, compared to the mucosa of the nose. So what do you think about it?
يعني يدخن بدل ما ياخذ يدخن ماريجوانا.
Oh, and you know, there is, in fact, there is for the tetrahydrocannabinol, it's been approved in some states by the FDA to be used with terminal cases as smoking. But don't forget, smoking is not absorption through the nasal cavity, it's absorption through the lungs. So it's a different route of administration.
Thank you. Okay. I would like to thank you, Dr. Abir, for your nice presentation. Let's go to the next one. Dr. Marwan Akashem. He is specialized in cancer tumor treatment center. He is the director of Dar al-Shifa Tumor Treatment Center, chairman of Hematology Oncology Division at King Hussein Medical Center, and he got a fellowship from Medical College of Wisconsin in Hematology and Oncology and Bone Marrow Transplantation. He will present Cancer Therapeutics in 2015, what you need to know. Welcome, Dr. Marwan.
Thank you, Professor Hassan. Thank you. Good afternoon, everybody. Let's get started. Just a briefing about cancer in Jordan. Are we talking myth of the increased epidemic of what we hear from the news, or we are talking about facts? So we refer to our National Cancer Registry at the MOH. And they gave us good figures. That was in 2011, around 5,000 cases of new cancer incidents. The population at that time was about 5 million. So now we are doing the census nowadays in Jordan. And as you can see, there is lots, predominantly females over males. Maybe because of checkup for the breast and the cervical pap smear and awareness more among women than men. And this is the distribution in general for the incidence of cancer. We can see here females, then in the 60s you get males more. I can reassure you that in Jordan, compared to the greatest nation on earth, which is the USA, we are doing fine. Jordan is 120 per 100,000 cases. And in females also we are doing fine. In Jordan our figure is not alarming. The predominant cancers in males, you see number one, lung and colon, and in female, breast and colon. And the age standard rate is 15 per 100,000 among colon cancer incidents. Thank God we are not among the first 20 nations with the cancer colon. You can see the distribution of cancer among the ages of the population. It has certain predilection. And we all know that cancer, we get more cancer as we grow older. We cannot do anything about it. We age with years, but we can't stop smoking. And you know all these nasty things coming out of the smoke, affecting our health. And we can cut down on alcohol. We can lead a more active life, not sedentary life, and we can watch our weight. We need to eat healthy. And also cancer, some predilection, it runs in families, certain types of cancer. If we find any alteration in our bowel habits, we need to check with doctors, not to drink Yansun, Mirami, or Thyme. And patients who are diabetic are at more risk of developing cancer. The story of vitamin D, which is now the mode, scientists look at the northern latitude of the globe and southern latitude of the globe. They noticed more incidence in the northern part of the globe rather than the southern part, which is more exposed to sun. So this came the truth about vitamin D, and studying cells and tumors in mice with vitamin D, they could come up with that vitamin D promotes cellular differentiation, decrease cancer cell growth, stimulate cell death, apoptosis, and reduce tumor blood vessel formation, which is angiogenesis. And there is a bulk of studies ongoing. At the moment, they are looking at patients who already developed adenomas in their colon, and they gave them calcium and vitamin D, and they are watching them for recurrence. And the study will be completed in 2017. As we know, the colon tumors, they come up from the adenomas, and they develop along the years into cancer. We need to do screening, and these are the recommendation guidelines from the American Society of Clinical Oncology, as well as we need to do screening for females above the age of 40. Few words about chemotherapy. Chemotherapy is good in early disease, in early cancer, in stage 1, stage 2. In stage 3, stage 4, we are palliating the tumor, we are not curing the patient, and the patient is having the burden of the disease, also is having the burden of the chemotherapy side effects. I think one day will come a time when our fourth generation, they will tell us what they were doing to our cancer patients. They were torturing them. The problem with the chemotherapy, that the cancer cells, as a whole, the tumor, it harbors a couple of really bad cells, which they have very heavy machinery, which is called the P-glycoprotein pump, which pumps out the chemotherapy once it's entered the cell. And this is the problem. We do CT scans, everything is clean. After 6 months, 1 year, you x-ray the patient again, and he's back with cancer due to these bad cells where they remain in the body. Besides chemotherapy, in the 90s, they came up with the idea of targeted therapy. We want to target selectively the cancer cells. And instead of giving more standard of care, which is one size fits all, we start selecting our patients, putting them into groups. A group of patients with the same syndrome, treating them differently, according to molecular targets. We resort to molecular studies. And the curves right now with chemotherapy in stage 4, we're talking late disease, not early disease. With chemotherapy, the curve will dwindle and all patients will die eventually. With the hypothetical targeted therapy, there is a plateau, which is good. I was telling you about diversifying our patients and putting them into category. And the best example is the breast cancer way of treatment. We look at the stage, we look at the size, we look at the number of positive lymph nodes in the axilla, we look at the hormonal status and the grade, whether it is well differentiated, moderately differentiated, poorly differentiated, and the HER2 status protein. Estrogen receptors, it's all over the body, the brain, the heart, and the bone. And the first targeted therapy was tamoxifen, which was not beaten till now by other drugs. It's still the standard of care. And we target the estrogen receptors with the tamoxifen. Nowadays, we use gene profiling to put our cancer patient into certain categories so we treat more personalized therapy. So the breast cancer patient, we can put them in one of these categories. These categories, they have different survivals, as we can see. The bad ones, the good ones, along the years. So that we deliver more chemotherapy, more heavily treat patients rather than treat the good ones. There is a test nowadays, it's called oncotype testing, which resort to 21 genes, and we do next generation sequencing for genes, and we put our early disease patient, a patient with breast mass 2 centimeters, there is no axillary lymph nodes, she is estrogen positive. Should I give her hormonal or should we go with her with chemotherapy? In our area in the Arab world, we don't know. We send specimen archives to Europe, to America, to tell us where to head. Because we can stratify our early patients into low risk, intermediate, high risk. The high risk group should be given chemotherapy, and they benefit from chemotherapy as the curves can tell. There is a difference between this group, this group, this group. They are all not significant to the chemotherapy, go with hormonal. But this group, they benefit from chemotherapy. So we are getting more personalized. And to get you into more flavor, the malignant cell have so many proteins on it, in the surface or deep inside it. And thank God we are in the era, we are targeting almost every protein according to the malignancy affected. So every protein, it has its own drug. As you can see, the story starts with some abnormal signal, ligand coming in touch with the cell and shift gear the cell, turn it into malignant cell with more differentiation and more chemo resistance with angiogenesis, metastasis, spread of the cell. And in addition, we are targeting these proteins with liposomes, with immune toxins, immunocytokines, different radionuclear materials. The angiogenesis story started with the tumor can survive up to 2 millimeters on the nutrition from the environment, microenvironment. But once it grows further, it needs blood vessels. And as the tumor grows, it secretes VEGF, asking the body to provide it with vessels to grow more and more. So, thanks to the pharmaceutical industry, they developed something, a protein to block this receptor and prevent further angiogenesis, which is called bevacizumab. And then the oncology family start using this drug to block blood vessels formation we're talking stage 4, in metastatic colon cancer, in metastatic non-small cell lung cancer, metastatic breast cancer, renal cell cancer, GBM brain tumors, and all proven to improve overall survival. As you can see, when we go with chemotherapy alone, look at the color chemotherapy, the gray one. If we add the biological, we buy more time for our patients with these biologicals. Now that the colon cancer population, we are shifting more than 2 years of survival with these biologicals. They used to live for 1 year with chemotherapy, now up to 2 years with these biologicals. The toxicity of these biologicals is, well, it's not awesome. We're talking about reversible hypertension, some sort of bleeding, I never seen that, and some well-tolerable group of drugs. These